Well, thank you very much, and thank you very much for that favorable book review. And I would take note that I say that not simply because I have a commercial interest. The book is free online through the National Library of Medicine, so if any of you would like to have a look. Thank you very much. I appreciate the comments of Professor von Braun and Professor Naumann because they're very in sync with what I have to say today. And I'm grateful for the chance to be able to talk about efforts that are underway and hopefully can be pursued despite the unfortunate political circumstances in which my country and others are currently living. And I will be focusing on the efforts that many of us are trying to make to overcome those political impediments to do some interesting things that benefit humankind. About 2 months ago, several hundred of us met on another set of holy grounds, the Cold Spring Harbor Laboratory in Long Island, to talk, as the cover of the meeting book illustrates, about the origins of our understanding of the genetic basis of cancer and the way in which an understanding of how mutations and other both genetic and epigenetic changes affect the transformation of cells into cancer cells has allowed not simply a deep understanding of this disease, but new molecular tools for diagnosis, and for choosing and developing new therapies that allow targeted treatments and immunotherapies. And we also discussed epigenetics and new kinds of combinations of therapies that may be useful in the future. But one thing that was not discussed in great detail is the question of who benefits from these advances. And even within an advanced economy like the United States, there are many people who are not being treated at NCI-designated cancer centers who are not receiving the full benefits. But of course, the situation is much worse elsewhere in the world. And there are many reasons why there is a deficiency of use of new knowledge that's generated by research, and that they are encapsulated by these three factors, namely how complex cancer actually is. It's not one disease, it's many different diseases. Maybe every cancer is actually unique. It's also impeded by other kinds of shortages of inadequate healthcare systems and workers, and especially at the moment, a lack of political and moral commitment to doing something to try to counter the effects of cancer. So I'm going to talk about some of the ways in which we can make progress against these deficiencies. And for some reason, not everything is showing up here. But one of the things that will be an undercurrent in everything I have to say is what's happening politically in the US. And I summarize that with these things that were unfortunate obstacles to trying to do a better job in enforcing and deepening our understanding of cancer and applying new knowledge in a useful way. And this was a list that I made in 2018 in the first Trump administration, when many of these were threats, proposals, as opposed to actualities. And as I think many of you will recognize, that many of the features of what sometimes is summarized as America First, could be advanced countries first, have actually become actual factors in our lives today. And these will be undercurrents of everything that I'll be saying. Now, there's reference made to some of the problems that we face when we think about cancer globally. One is that the number of cancer cases and cancer deaths are rising, especially as life expectancies increase in poor countries. This was an estimate made in 2002, but has been more or less come to pass over the ensuing years. And those increases are particularly felt and what are referred to here as the LMICs, the low and middle income countries. Secondly, cancer is complicated. The rates of different kinds of cancers vary in different countries, so we have to understand the epidemiology of the disease before we make plans for how to confront it. And we have a deficiency in healthcare workers, physicians, and many others who are involved in delivering healthcare, which are displayed by this world map that shows the number of physicians in relation to the size of the country. And the most dramatic feature here is the paucity of physicians in Africa, especially sub-Saharan Africa. Some of the principles that underlie what I have to say are listed here. First of all, because when we think about cancer, sometimes the first thought is, oh, cancer is a very expensive disease to control and to treat. But not everything that we can do, even now, to control cancer is prohibitively expensive. Not all places that progress can be made are prohibitively poor. And we have to keep in mind that every country that makes an effort to develop plans for better cancer control has its own characteristics that need to be taken into careful consideration. And it's also useful to remember, as many reports have done, that the benefits of controlling cancer extend, as they do, as is true for other diseases as well, extend well beyond health itself to issues of diplomacy and reputation, security, and importantly, economics. One such initial report that made the case for the economic benefits of healthcare, especially in cancer and other severe diseases, came from the WHO, an organization which is now under tremendous economic stress. In 2000, when a commission to which I was a member, chaired by the economist Jeffrey Sachs, laid out the cost benefits of using global health as a political as well as a scientific tool. The U.S. has joined in on this. The National Academy of Science and Medicine have written reports, the first of which was published in 1997 on the American interest in global health, which not everybody in the United States appreciates, but pointing out that we have a direct stake in the health of people everywhere in the world because of humanitarian concerns and also what we call enlightened self-interest, including economic interests. And this was echoed in many ways by a report that for which I was a co-author in 2008, in which this view was remarkably well illustrated by the development of the PEPFAR program, which has saved many millions of lives, especially in Africa and other poor countries, through the control of HIV/AIDS. There are at least three things that I'd like to illustrate as examples of the kinds of things that can be done. Setting up collaborations between rich and poor countries that set a precedent and a high standard for the kind of work that can advance our concept of how we can confront cancer in poor countries. And I'll talk about the Uganda Cancer Institute. Secondly, I want to talk about some groups that I've been involved with, the Gates Foundation, the National Cancer Institute, and WHO, that set plans for how the knowledge accrued in the rich countries can be applied, and the funds available in rich countries can be used to try to advance global health generally and cancer global health in particular. And I'd like to remind you at the end about other features of the scientific enterprise that can be important in trying to improve the status of an understanding of cancer and the control of cancer, even in poor countries, and those include publication practices. So let me start with the Uganda Cancer Institute, which was founded as a result of work that began in the mid-1970s when Dennis Burkitt, an Irish surgeon working in Uganda and other parts of East Africa discovered a cancer known as Burkitt's lymphoma that proved to be treatable with a single cytotoxic agent, Cytoxan, and was caused by a newly discovered human virus, illustrating the power of science done in poor settings to eliminate disease everywhere in the world. Here's an example of a young boy treated with Cytoxan who underwent a rapid remission. This attracted and this is an illustration of the Epstein-Barr virus, which was isolated from cells and those tumors that were sent back to Oxford, England, and worked on by Tony Epstein and his colleagues at Oxford to discover the Epstein-Barr virus, which is the cause of other kinds of cancer and cause of a widespread infectious disease known as infectious mononucleosis. All this work attracted the attention of the National Cancer Institute, and several of our colleagues went to Uganda to negotiate for an opportunity to work with clinicians at Makerere University, where many of these cases of Burkitt's lymphoma were seen. This relationship, which was highly beneficial for many years, was then disrupted by the arrival of autocratic leaders of the country, especially Idi Amin and also Apollo Abate. Now the country is under a more beneficial leader, Museveni, who continues to be the leader of the country. As the country came under better control about 20 years ago, a NCI designated cancer center in Seattle, Fred Hutchinson Cancer Center, picked up where the relationship with the NCI had more or less broken off, and has been a very close partner with the Uganda Cancer Institute, providing personnel, training, housing for its own people who go to Uganda. And in 2011, I had a privilege of attending the groundbreaking for a new research building, and this remains one of the triumphs of U.S. African collaborations and advancement of an understanding of cancer both locally and globally. This example has been used as a template for the development of other kinds of relationships, a few of which are illustrated here between cancer centers at major American universities and in countries throughout Africa. And this is only a partial listing. Second, I want to talk about the example of establishing funding opportunities and advisory groups to guide the development of science that might affect our ability to cope with the incredible challenge posed by cancer globally. And just to say a couple of words about the effort that was made by the Gates Foundation about 25 years ago to establish important ideas that need solution, called grand challenges. The grand challenges concept was one that was invented by a mathematician, David Hilbert, well over a century ago, when he established the grand challenges in mathematics. And Bill Gates recognized this might be the kind of challenge that would appeal to scientists of all kinds, and he established a board and provided the financial resources to attempt to challenge the scientific community to solve problems that were important for control of disease in poor countries. And a large group of us developed the 14 grand challenge ideas, announced widely in Science magazine, and resulted in awarding over 40 grants. And in some ways, the important thing was not just the useful science that came from some of these projects, but also the development of new forms of grand challenges, including the so-called cancer grand challenges that are currently being funded by the National Cancer Institute and Cancer Research UK. And many of these grand challenges have been influential, and there's at least one that's currently directed specifically to attempts to control cancer in ethnically diverse groups of people. Let me say a couple of things about what has happened at the National Cancer Institute over the last 15 years, and with some mention of some of the threats to that activity. So when I became the National Cancer Institute director in 2010, one of my goals was to convert a somewhat poorly organized effort to do some work in poor countries into an official center for global health. And the initial director of that center, Ted Trimble, and I wrote an essay about how cancer control could be integrated into global health. And the print here is small, so let me just tell you what the major ideas were that we developed as a result of many consultations with scientists, both American and international, in trying to develop the large concepts around which that center would be developed. And the first was to recognize in every country in which we work, what is there, what is the problem? Because as I've emphasized, the cancer problem is different in every country and the resources are different. And the idea of developing national cancer plans in conjunction with advisors from the NCI and elsewhere was a staple, an important ingredient in how we thought about this. The second way is to recognize that cancers in poor countries can be caused in as many as 25% of cases by infectious agents, mainly viruses, and also some bacteria and parasites, and that preventive measures, which are critical to control of cancer in poor countries, may include vaccines and other means of controlling infections. Doug Lowy, who will be speaking later this morning, will address this in a more thorough way. Third thing is to recognize that prevention of cancer is frequently also an effort to control other diseases, and that obesity, tobacco use, alcohol use, other drugs can also be factors in the etiology of other diseases. The fourth thing is to recognize that not all cancer treatment is about cancer itself. It involves having appropriate health systems that allow efficient screening when screening is appropriate, that allow access to treatment and symptom control, because access itself is sometimes just as important as the ingredients that go into and the scientific strategies that go into treatment and symptom control. That modalities of healthcare like surgery sometimes are deficient, and improvement there can be incredibly important. And having solid health systems that are adequately supported financially can be very critical. And then the other factor is a more abstract one, which is to harness the enthusiasm of youth, look for partners in developing the capacity to make both science and the practice of medicine more available in poor countries. Just give you a couple of examples that this may not look like a slide about cancer, but in fact, cancer patients are treated here as would be patients with any kind of disease, and developing the right level of human talent, physical infrastructure, adequate financing, both from home country and abroad, having political will and means to provide access and communications between health workers and patients, all incredibly important factors in trying to confront any disease, including the set of diseases we know as cancers. One simple example that I find useful as a means of explaining this is to think about surgery, which is, in the words of one of my colleagues, a neglected stepchild of public health, is a very important feature in cancer surgery, is rare in poor countries because surgical equipment and anesthesia and surgical talent are frequently unavailable. And yet surgical diseases account for a lot of disability-adjusted life years that are lost. My colleague at Memorial Sloan Kettering, Peter Kingham, has done a superb job in providing an inventory of surgical facilities available in poor countries, and illustrates the importance of having those available, not just because you can do things like remove a colon cancer, but you can also treat other diseases like the simple twisting of the intestine we know is volvulus, and he's shown here with a grateful patient whose otherwise lethal condition was relieved by surgery. One of the things we learned as we began to develop the ideas for the NCI's Center for Global Health is that we can't, this job is just too big for one agency or for one country. And we organized meetings in collaboration with Cancer Research UK of funding agencies from over 15 countries, and wrote about the kinds of things that we could expect to usefully and efficiently pursue through common actions. And some of those are tobacco control, which is, even though tobacco is under better control than it was, and its noxious effects on human health are widely recognized, we still have to acknowledge that as some countries become richer, people enjoy the smoking of tobacco, and tobacco use becomes more frequent, and we have not made a global success in attempting to control tobacco use. And this is a place where international actions by many different groups, and perhaps this is a group that could be among them, can be incredibly important in trying to prevent some of the deaths that are anticipated from tobacco use over the next century. A good example of how international collaborative work just to gather up vaccines and distribute them can accelerate the use of cancer-preventing vaccines like the human hepatitis B vaccine, a very cheap vaccine, which is now almost universally received by the world's population, was rapidly accelerated by the development of Gavi. Let me just say a few words about one of my current activities, currently under siege by financial and political headwinds, is the WHO Science Council. This was a council established by Swaminathan and Tedros, the head of the WHO, to provide new technological information to the World Health Organization with the intention to improve global health. And in 2021, I was asked to chair this group, and there are actually some, I don't know if Edith Hurd will be here, but she is a member of this group, and I assume you see some of your friends here. This group has been hard at work developing advice about a variety of topics, at least two of which are highly germane to what we're discussing here, namely the control of cancer. One of those, the first topic we took on, was to provide advice for how to accelerate access for genomics, because virtually all cancer care these days, in my view, has to begin with an analysis of the cancer genome, and that can't be done unless genomic facilities, both human skills and machines, are available for analyzing cancer genomes. And we made a series of recommendations, not all of which I will cover, that address how we promote the use of genomics globally, how implementation of those techniques can be applied, what kinds of collaborative activities are most critical to achieving worldwide installation of genomics, and how we address the ethical, legal, and social issues that are raised by the use of genomic techniques everywhere. And I just want to emphasize that one of the lasting legacies of our report is the establishment of a genetics committee, an international committee known as TAG-G, that is currently in operation but is now threatened in its operation by the loss of funding, especially from the US, to WHO. And this group is currently threatened with a dramatic reduction in its activities because the US is not recognizing the importance of global collaboration to enhance the use of genomics throughout the world. I'm not going to go over these others in view of time, but I would just point out briefly that we have a third report on digital health, and also a feature of worldwide healthcare that is going to be critically important if we're going to make progress against cancer in poor countries, and that is the use of digital tools in healthcare that are as efficiently used as digital tools are in commerce and entertainment and finance and other kinds of human activities. And the goals of our council were to identify the deficiencies in the use of digital technologies that are impeding access to those tools to promote health and to improve research and to promulgate public health practices that can help control the frequency of cancer in populations. We've tried to portray these efforts in 4 simple terms in the report that is yet to be released that emphasize the importance of connecting countries and platforms to make sure that we have a uniformity of purpose, that we educate public health workers and the public and how health services can be provided digitally, that we provide incentives for countries to invest in this kind of infrastructure to improve health and evaluate the success of these systems as they get developed. Finally, let me just say a couple of words about the international features of science. Meetings like this one and many others are incredibly important in trying to maintain a high international standard, building organizations and joining organizations to be sure that we're making full use of the collaborative skills of different groups, using international methods to improve training, something which I'm particularly concerned about at the moment. America has been a major source of training of people from abroad, especially from poor countries, and that is currently threatened by our own immigration and visa policies. One other feature that sometimes gets neglected here, the importance of publication practices. I'd like to remind people that in Holland, a long time ago, a famous surgeon in Holland liked to share his knowledge of human anatomy by inviting people from adjacent towns to come and see what he knew. This illustrates the contrast between a public library like the New York Public Library and a monk living alone in his cloister with a rich set of books. But in trying to change the culture of science, which I think is unfortunately built on restrictive access to the books and journals that contain the information that we have generated, we've changed that dramatically over the last couple of decades through digital public libraries like PubMed Central and the equivalents in Europe, by new methods for publishing, especially open access publishing and open peer review, and greater access through preprint servers that were initially developed in the physics and mathematics communities, but have been applied in biology, especially during the recent pandemic. It's taken so long for this to happen because for a variety of features that have to do with the profit that's available through publication. But there have been some countervailing forces in the last several years. and I particularly point out the efforts made both in the U.S. by the U.S. Congress some years ago to require a deposition in an open access digital library, and an administrative recommendation during the Biden administration to reduce the temporal embargo on such deposition. And in Europe, Plan S has been a powerful force for requiring open access, with the funders understanding that if their work is going to be fully effective, it has to be available to all for access. So I think there are things that can be done, even in a difficult political environment that we're currently facing, to pursue collaborations that set an important standard by establishing more groups that fund research and provide advice for how countries and international bodies and scientific organizations can move toward a better world, and by strengthening the sometimes unrecognized international features of science. And the end here, of course, is multiple: better understanding of cancer, improving our ability to prevent and treat cancers, better health systems that affect the approach to all diseases, and the economic and other humanitarian benefits that result from better health throughout the world. So thanks for listening, and I'll be happy to take questions and look forward to conversing with many of you.